So good evening and good afternoon or good morning, according to the time where of your time zone is. So my name is Dr. Roseline D'Oiron and I work in Paris Bisset Hospital. And I would like to thank the organizers of the 25th Congreso Argentino de Hematología for this invitation and the very kind invitation to present on hemophilia in women, diagnosis and management of girls and adolescents and adults. I'm sorry, but my Spanish is not good enough to make this presentation in Spanish, so I will do it in English. Here are my conflict of interests. And the agenda for this presentation, I will touch a few words about carriers of hemophilia and the fact that they bleed too, and we can call them women and girls with hemophilia. Then I will explain how many they are and how many they are with hemophilia. I will explain how to document delay of diagnosis and why early diagnosis matter, and some areas of improvement for future and few words of conclusions. So first of all, carriers of hemophilia, we know that some of them are called women and girls with hemophilia. Indeed, when you ask people usually what hemophilia means, they think that this disease, people are going to die with just a very small wound, that it is a royal disease. And you see on the right, the Queen Victoria, as you know, she was a carrier of hemophilia B, and that was one of her ancestors of the Starevich, Alexei, who had some bleeding problems and mainly some joint problems. And indeed, hemophilia is a joint disease as well. We know so far very little about the bleeding episodes in Queen Victoria, and especially when she was a young girl. What about her menstruation? We don't know exactly what happened on that regard. Indeed, carriers of hemophilia may have low factor levels. This is coming from data in Sweden, and that was a survey in cohorts of carriers of hemophilia where the factor levels were assessed in more than 200 women carriers of hemophilia. As you can see, the distribution, those who had low levels between 5% and 0, or so what is the so-called severe or moderate hemophilia, were extremely rare. And in this cohort, there were no women having such low levels. So these situations are indeed exceptional. However, if you look at the patients that had factor levels below 40%, which is the definition of ISTH of hemophilia so far, this was not rare because about 23% of those women had indeed low factor levels. So we can say that mild factor VIII or IX deficiencies in carriers of hemophilia A or B are not rare, but probably they are not very well looked for, and a lot of them are underdiagnosed. When we say carriers of hemophilia in women, so we have seen that some of them, about a third, may have low factor levels. And we know as well that about a third of them do have bleeding experiences. However, the correlation between the factor levels and the bleeding experiences are not completely overlapping. But these women experience very specific bleeding related to heavy menstrual bleeding or to postpartum hemorrhage, and these are frequently recorded as the bleeding episodes in women with hemophilia. Of course, they may have other bleeding experiences as well, but these are really extremely frequently recorded in the bleeding experiences in those women who have hemophilia. One of the difficulty is that the majority of them has been assessed when they were adults usually, and the ISTH bleeding scores sometimes did not really reflect what happened at the time and compared to what they had in their past history. When you look at the ISTH bleeding assessment score in carriers of hemophilia, you see in this publication a median score at 4, but some of them may have extremely high level of bleeding scores, and some had a normal bleeding assessment tool. And on the right side of this slide, you see that the correlation between the bleeding score, the ISTH bleeding scores, and the factor level is there. However, the correlation is quite weak, as you have some women with a very high bleeding scores, despite the fact that they have normal factor levels. And at the other hand, you also have some women with low factor levels that do not have high bleeding scores. So the correlation do exist, but it's not extremely high. So how many carriers we should have in a cohort of a population with hemophilia, and among them, how many women and girls do have hemophilia? This is the work coming from Carol Kaspers that has been done a few decades ago. And she described in the pedigree of the families followed in her center that for one man with hemophilia, you had up to 5 potential carriers, and among them, 1.5 were actual carriers of the variant, of the factor 8 or 9 variant mutation. And if we take into account that about a third of these do have low factor level, we should have for one man with hemophilia, 0.5 woman or girl with low factor levels, so having herself hemophilia as well. So to express this, you can just say that for 2 men with hemophilia, we should have 1 woman with hemophilia. So indeed, again, this is not rare, but likely underdiagnosed and still unfrequently included in national databases. This slide summarizes some of the national registries or cohort that has been published, or some of the data that are regularly published in annual reports in national databases, and also from the WFH survey that regularly publish the number of and the number of persons with hemophilia, male or female. You have the circles, just in blue, you have the men with hemophilia, and in pink, the women with hemophilia. And one disc represents 1 year. The oldest data are just in the middle of the center, and the more recent data are just at the external side of this circle. And you can see that the distribution of the proportion of women having hemophilia among all the persons with hemophilia is increasing in quite a lot of countries, especially in the English-speaking countries like Canada, US, and UK, while it is still underrepresented in some other countries. This is likely in relation to development of programs and advocacy programs from the national organization, who are in those countries extremely active, and a good collaboration with health professionals may contribute to better recognize those women with hemophilia. So how to document delay of diagnosis, and what are the proof of some delay of this diagnosis of those women who have hemophilia? If you look at the median age at diagnosis of severe and moderate hemophilia in the data coming from the CDC in USA, you see that for the diagnosis of girls compared to boys, there is a 6.5 months delayed for severe hemophilia, and there is something close to 40 months of delay in the moderate hemophilia girls compared to boys. And this was despite the fact that they had similar number of bleeding experiences. When you look now what is happening in mild hemophilia, and these are the data coming from our national databases in France, France Coag, we compared all the girls included with factor levels below 40%, and these numbers were 442 girls and women, and they were matched with the same number of boys and men with mild hemophilia, between 5 and 40% of factor levels. They were matched on type of hemophilia, A or B, lowest recorded factor 8 or 9 levels, plus or minus 2%, year of birth, plus or minus 3 years, and the year of inclusion in France Coag to avoid bias related to different practices according calendar period. The result is that just here, you see that the median age at diagnosis in men and boys was a little bit above 10 years, nearly 11 years old, while in women and girls, it was nearly 17 years old, which means a delay of 6 years. So for these girls diagnosed quite late, after usually after their menarche, this is not possible to make the support which is necessary to anticipate menarche and avoid heavy menstrual bleeding. So why early diagnosis matters? For that, I will share one of the story of one of our patients. She had a first bleeding episode just after a dental extraction when she was 8 years old. She had heavy menstrual bleeding since menarche, but at that time it was not recognized. However, she had a very poor quality of life with a very poor sleep quality, a lot of pain, a lot of tiredness, and missing schools 2 or 3 days each cycle. She was diagnosed with asthma related to exercise, which I guess was a wrong diagnosis, as she likely was anemic and with iron deficiency. And she had to stop to participate to sport activities because she was having dyspnea as muscular activities. She finally arrived in an emergency room for a short unconsciousness, and that was related to severe anemia and iron deficiency. She received iron supplementation at that time, but it is only when she was more than 16 years old that heavy menstrual bleeding were finally recognized. She was treated with tranexamic acid, but with a low dose, which was not effective. So she finally was receiving a hormonal therapy, and that was successful in better control of her heavy menstrual bleeding. She finally had her first coagulation test when she was 16 and a half years old, and this showed that she had a prolonged PTT, leading to the diagnosis of a low factor 8 level at 25%. She was finally referred to hematology clinic, where second-line tests were performed to avoid von Willebrand disease. At that time, the diagnosis of exactly the same similar story was diagnosed in her mother. She had a story of a history of heavy menstrual bleeding for years, and she had her first coagulation test when she was 41 years old. It's not just one, it's just 41, sorry. Finally, the genotype showed that Claire and her mother both had a nonsense variant mutation in the factor VIII gene, so they were both carriers of severe hemophilia A. And it is not the end, because when you have the diagnosis, you have to follow as well these women. Claire had a very low tolerance of hormonal therapy, leading to vomitis, and so she was not taking the pill on a regular basis, and that led to resuming to heavy menstrual bleeding again. So finally, she received the right tranexamic acid dose quite recently. That was last year when she was nearly 16 years old. As you can understand, the diagnosis is not just one day. This is a very long process, from the first symptoms, then the introduction of the first symptomatic treatment, then when the recognition of the bleeding issues is made, then when you can a little bit more focused on which type of bleeding disorders might be involved, then when you can tackle the group of hemophilias that could explain the factor VIII deficiencies, and the definite diagnosis was made at the end of this very long process. So this step-by-step diagnosis is taking quite long. If you take the story of this girl, it took more than 8 years to recognize that she had a bleeding issue after a first bleeding episode, which was nearly 4 years after the first heavy menstrual bleeding. And the definite diagnosis was made 4.5 years old, 4.5 years after the first heavy menstrual bleeding. If you take the calculation of what does it mean in terms of quality of life, as she was missing school each cycle 2 to 3 days. It means that she was having bleeding episodes more than 450 days with heavy menstrual bleeding, and she was having more than 140 days off school. So when you look at this calculation, I think this is quite obvious that it is really impairing very deeply the quality of life of these women. And this is why early diagnosis matters, to reduce the time with a very poor quality of life. So areas of improvement now. I think this is very important to understand the barriers to diagnosis. We know that neglected or late family inquiries make that the fact that you don't diagnose other potential persons in the families that might be affected. A very difficult point is about the recognition of what is normal and what is abnormal. And heavy menstrual bleeding is indeed very difficult to diagnose when you are not aware about what are the means in order to differentiate between what is normal and abnormal. And I think that as healthcare professionals, we really underrate the burden and the impact on quality of life of such bleeding episodes that are coming so frequently each cycle. So each month you have a bleeding challenge, and it is not well rated as well from ourselves regarding the severity of these bleeds, and usually this is not recognized as very important. However, it is really impacting deeply the quality of life. So improving the knowledge is really key, and education is really important in order to avoid those barriers to diagnosis. Some tools and strategies have been developed, as you know, assessing the bleeding assessment tools and the scores is very important in order to record other locations of bleed, and try to being educated and try to share with other healthcare professionals how to perform those bleeding scores is also a lot of help. And you have one example here on this very simple without, this is just very direct on the first page that you see on that website. It is very easy to click and to have online this score performed. And this is an example of the item regarding menorrhagia. It is also recognized that to recognize menorrhagia, you can use the PBAC or the HIGEM score, also called Pictorial Blood Assessment Chart Score. And if you have a score above 100, or which means that you have menses above 80 milliliters of blood each cycle, this is the definition of heavy menstrual bleeding. But I never had women coming to a clinic and just saying, I am bleeding more than 80 milliliters of blood each cycle. So I think that's very important for clinicians to ask the right words and the right questions in order to recognize with some very standardized way potential words and more appropriate and more easy to understand language in order to help those girls to diagnose if they have or not heavy menstrual bleeding. This has been the work of recently the assessment for the von Willebrand disease. As you know, there has been some new definition that has been discussed in the whole guidelines process. And these are all the items that are listed: more than 8 days, consistently soaking through one or more sanitary protection, or change every 2 hours on multiple days, requiring more than one sanitary protection item at a time, or requiring to change this protection during night, or when you have passing some blood clots. This can help in order to use these words that can be understandable by those women and those girls. I would like also to insist on the role of first-line actors that maybe healthcare professionals have to empower in order to be able to recognize, like recognize heavy menstrual bleeding, like pediatricians, specialists in the emergency rooms, general practitioners, gynecologists, dentists, anesthesiologists, surgeons, school nurses, social workers, or any person close to young girls. I think that to learn how to recognize abnormal bleeding symptoms should be some educational activities that should be developed, and also to learn how to record family history of bleeding. And this should lead to the first prescription of a blood count, of measurement of the iron stocks, and some starting the coagulation test. But even if you don't perform coagulation test, these two first points should lead to referral quickly to a hemostasis specialist. It is important that healthcare professionals at the first line have an organized network in order not to take too long to have these girls referred. And before they get their appointment and their first appointment, starting symptomatic treatment without delay is also a lot helping. Another point that could be implemented is to differentiate the genetic diagnosis of carriers of hemophilia and the bleeding diagnosis for those who do have indeed a bleeding disorder as well. Usually you perform such kind of test in the same way when you have an adult woman coming when she wants to know if she is a carrier or not of the familial hemophilia. And sometimes this is just the first time that she will get a factor 8 or factor 9 level assessed. To differentiate between these two, it might be helpful so you can just perform at a very young age a bleeding assessment using the coagulation test to measure factor 8 and factor 9, and also to perform a bleeding scores, because we know that the correlation with the factor level is not that good. So this might help in order to anticipate menarche in those women. Finally, symptomatic treatment can be started before a definite diagnosis. Just remember this, HAPPY. This means that these are the 4 pillars of the symptomatic treatment that can be extremely useful to improve quality of life of women with heavy menstrual bleeding. This is true for carriers of hemophilia who do have hemophilia, and this is also applicable to other types of bleeding disorder. These 4 pillars are hormonal treatment, tranexamic acid, and that probably is the first one to start because it is usually extremely effective if you use it at the right dose, which is 1 gram 3 times a day for an adult person. Painkillers, because those heavy menstrual bleeding usually are related to higher rate of pain, and correction of iron deficiency. Of course, when the diagnosis of the bleeding disorder is made, then specific treatment may also add some additional effects. And you can use 1, 2, 3, or 4 of these pillars in combination to this specific treatment, like factor concentrates or desmopressin. Finally, this is the great achievement that has been done this year. Nomenclature of women with bleeding disorders was finally confirmed by ISTH, and we know that previously they were called carriers of hemophilia with low factor levels, but that was not satisfactory, and finally it was admitted by ISTH that those women who are carriers of hemophilia and who do present low factor level should be called women or girls with mild hemophilia, moderate hemophilia, or severe hemophilia according to factor level. And for those who do have a bleeding phenotype, they could be called symptomatic hemophilia carriers or assumptic hemophilia carriers if their factor level is above 40%. So to conclude, diagnosis in women and girls is delayed compared to male with the diagnosis of women and girls with hemophilia is delayed compared to male counterparts. Mild hemophilia is not rare in carriers of hemophilia, but awareness is still needed to be increased. Earlier diagnosis of girls with hemophilia enables anticipation of menarche and heavy menstrual bleeding and prevents the poor quality of life in those young girls. Early introduction of symptomatic treatments is extremely helpful even before a definite diagnosis. Update family trees in families of hemophilia is extremely important and useful as well to avoid delays in diagnosis of these girls. And when diagnosed, a special attention at each age is really warranted and needed. And don't forget to develop research, because just the fact that you make some research on this topic, you will help the quality of life of these girls. I will also say that the diagnosis of the genetic and the bleeding risk in carriers of hemophilia, if you do diagnose one, you will not forget the other one. So this is a virtual circle as well. And finally, these are the 10 principles of care that has been developed by the Women and on Bleeding Disorder working group, developed by more than 10 different physicians. And this is dealing with the main topics that you should implement in order to help the care of carriers of hemophilia specifically, and women and bleeding disorders in general. With that, I will thank all my team here in Paris Bicêtre Hospital, the work that has been done by all the hemophilia treatment centers in France, contributing to France Coag, where that was leading to the result I could show you today. The collaboration that we do have with the patient organization at the national or European or world level, and also the group of EHAD. I will always learn something with these colleagues, and I would be happy to take any questions. Thank you very much.